Thank you very much to joining this symposium. I appreciate all the participants who visited Severance Hospital from afar on this Saturday morning. My topic in this time is the latest updates in hyper short duration AF ablation. Disclosure information. Many people are familiar with hyper short duration ablation. Some of you are already using it. And hyper short duration ablation is specified RF energy power for AF ablation, which is efficient in thin atrial tissue. Considering the mechanism of RF lesion generation, it can be divided into resistive heat, conductive heat, and convective heating. Resistive heating is a heat applied to the catheter tip contact surface by electrical resistance, and conductive heating is a lesion formation that occurs when RF energy is dissipated into the deep myocardium. In addition, there is convective heating, in which the blood or irrigated flow removes the heat from the catheter surface. So these various factors affect the creation of RF lesions simultaneously. In particular, tissue contact force, radio frequency power, and duration of RF energy delivery are elements that the operator can manipulate. Then how can the operator know if the RF lesion is being properly created? Contact force monitoring, voltage abatement, of an electrogram, impedance draw, are the typical surrounding markers for lesion formation. In addition, you can also monitor split potential or local capture failure. We have conducted several studies related to catheter design and contact force, and we previously reported the 35-watt endurance ablation for 30 seconds in each point resulted in better rhythm outcome than 25-watt empirical ablation. And after using the mesh-type flexible tip catheter, ablation outcome was improved in my institute. And recently, we compared the flexibility catheter and tactical catheter, which is a contact force monitoring catheter, but the rhythm outcome did not differ between two groups in this RCT. Hyper short duration RF ablation aimed to create RF lesion by relying on the resistive heating rather than the conductive heating. And since the LA wall thickness is usually less than 4 millimeter, resistive heat can create a conduction block as a primary surface lesion. Above all, since the single point ablation duration is short, the effect of catheter motion and tissue edema can be reduced by hyper short duration, and the ablation time also could be reduced. This is a graph you have seen many times. The larger RF power and longer duration, and the lesion size is larger, and hyper short duration is shallow compared to the standard RF power, but creating wide contiguous lesion, it is advantageous. It is standard, but it is hyper short duration. However, what worries anybody about hyper short duration ablation might be collateral damage, especially esophageal injury, and the risk of cardiac tamponade. However, in several studies, hyper short duration ablation did not increase the risk of esophageal damage, and the hyper short duration low flow irrigation was advantageous in LA posterior wall in rapidly creating superficial lesion and reducing the endocardial sparing. Endocardial sparing is a phenomenon in which, when the irrigated flow is increased, deep lesion is created by conductive heat, but paradoxically, endocardial surface burn is insufficient. Then, what about the hyper short duration PBI outcome? In this study, 50-watt PBI was with or without contact force did not differ the rhythm outcome. And in this RCT, 70-watt hyper short duration ablation resulted in significantly better rhythm outcome than conventional standard ablation group. So actually, I tried the same protocol with 70-watt, but found the chop formation on the flexibility catheter tip. So I reduced the power to 50 to 60 watt and increased the irrigated flow. Since we do not know how powerful of hyper short duration is, we thought that the RF energy titration was necessary. So we developed the software that automatically measured the atrial wall thickness in heart CT imaging, in particular areas where the thickness measurement is difficult, such as the appendage junction area, and they were automatically measured and validated with phantom model and resulted in results were analyzed in more than 1,800 patients. So we know the AF ablation complication risk is high in women, especially elderly ladies, and this the major complication and the risk of tamponade were significantly higher in the ladies older than 75 years old. It was because the left and right side, the antral wall thickness were significantly thinner in those older ladies at the CT scan. This RCT study compares the safety of energy titration during 60-watt high pressure threshold PVI using LA wall thickness software shown above. And because we use a flexible catheter, we titrate the RF energy without contact force. In the wall thickness group, 11 to 15 second ablation and each point was performed depending on the thickness, but we kept same 15-second ablation in control group. The procedure time or complication rate did not differ, and the rhythm outcome also did not differ between the two groups. That means that PVI endpoint is more important than RF energy titration. The following will introduce recently published or under review clinical trials evaluating the effectiveness of hypershort duration RF ablation. This is propensity score matched study comparing the hypershort duration versus 35-watt conventional RF ablation. As you can see, the Kaplan-Meier curves show perfect overlapping, and there was no difference in the efficacy and complication risk. However, the procedure time and ablation time of hypershort duration was remarkably short, so the procedure's efficacy was significantly high. During hypershort duration AF ablation of more than 1,000 patients, the procedure time was significantly reduced, and there was no difference in the efficacy. However, surprisingly, some patients complained dyspnea 6 months or 1 year after the procedure, and chronic PV stenosis was observed in 0.4% of patients despite antral PV isolation. It was higher incidence than conventional ablation. It is especially common in proximal AFib, young men, redo procedure, and inferior base. In these patients, RF delivery time should be further reduced. This study is RCT comparing the hypershort duration versus cryo PVI isolation at a 1-to-1 ratio. Cryo PVI shortened the procedure time and even more than hypershort duration ablation, and there was no significant difference in the complication rate, but 2% of frenulum paralysis complications were seen in cryo PVI group. There was no difference in rhythm outcome between two groups, so the cryo PVI showed the advantage of a shorter procedure time than hypershort duration in proximal AFib, where only PVI was performed. However, not all hypershort duration and cryo are equally effective in all PVI patients. This study compared the RF and cryo with propensity score matching in over 2,100 patients. And how differs cryo versus RF PVI? We have reported a similar rhythm outcome between cryo PVI versus hypershort duration RF PVI. However, in patients with large LA volume index, cryo PVI showed a worse rhythm outcome than RF PVI, especially the patient without extra PV triggers. In other words, PV-dependent atrial fibrillation with large LA, cryo PVI outcome was worse than RF antral ablation. It may be because 28 mm fixed size cryoballoon spares some area of PV antrum in large LA patients in this computation modeling study. This is RCT PowerFast 3 trial announced in latest ERA 2023 Congress, and investigators compared the 70-watt hypershort duration versus conventional RF PVI, but surprisingly, the first pass PVI rate was lower in hypertuburation. Moreover, among complications, stroke and embolic rate were higher in hypertuburation. The researchers used 70 watt as the Kottmeyer's protocol shown earlier, but the 70-watt protocol may induce chart formation, and rhythm outcome did not differ between two groups. As a sub-study of this power fast, there was a sub-stroke study was also presented. Of the patients included the power fast 3, 144 patients who underwent post-procedural brain MRI were analyzed, and the silent cerebral lesion were significantly high in hypertubuation group and persistent AFib group. Finally, this is a result of a very hypertubuation PBI developed by Abbott competitor. And this catheter, named the QDOT catheter, is a temperature-controlled catheter and has a 90-watt ablation protocol. When comparing the 90-watt very high hypertubuation PBI versus 35 to 50-watt PBI, the procedure time shortened by 5 minutes, but there was no significant difference in rhythm. So in conclusion, ladies and gentlemen, RF lesion is directly proportional to power, interface temperature, electrode diameter, and contact force. Hypertubuation PBI isolation significantly reduces procedure time by maintaining effective catheter stability and resistive RF energy. The safety of hypertubuation PBI did not differ to that of conventional ablation, but has a risk of a long-term symptomatic PB stenosis. Cryo PBI shows equivalent rhythm outcome with shorter procedure time compared with hypertubuation PBI. However, it shows a worse rhythm outcome in patients with LA volume index over 35. Thank you very much for your attention.